Hello, everybody. I'm gonna stab my wife. No. Ramika is on home hemodialysis. I'm her home hemo nurse. So, we're gonna hook her up to her machine. She's all set up here. We have dialysate, we have saline, we have her dialyzer, which is her artificial kidney. On this panel, we press a bunch of buttons so we could adjust the blood flow rate. That's the amount of blood and how fast it comes out of her body. The UFR, which is the ultrafiltration rate, that's how much of the nasty stuff comes out of Ramika's blood. And this is the dialysate flow rate, which dictates how fast the dialysate goes against the flow of blood inside the dialyzer. Now, the dialyzer acts as an artificial kidney. The blood inside the dialyzer does not mix with the dialysate. It actually runs right next to the dialysate in an opposite direction. The pressure of the blood and the pressure of the dialysate cause the ultrafiltration effect so that all the bad stuff goes from the blood to the dialysate, and any extra good stuff that the blood needs that's in the dialysate goes from the dialysate into the blood. That's all technical stuff that it took a while to learn. I'm still getting the hang of it. But the long and short of it is, this helps clean her blood. So, Ramika has in her lower left arm an arterial venous graft, which means there's a little pipe inside of her arm that attaches to a vein at this point and an artery at this point. The blood flow comes down her artery and goes through the vein. Going through the graft here is where we can access it. One needle will go here for the arterial side. One needle will go in this area for the venous side. The arterial draws the blood from her body, goes in through a series of tubes, comes through the dialyzer, gets all nice and spick and span clean, comes back out, goes in another tube, then returns in through the venous side. Basically, her blood leaves her body. Her entire blood supply leaves her body about 5 to 6 times within the 3-hour period. So it's about a cup of blood every minute. So right now what we're going to do is we're going to inspect the site here. Feel to make sure it's still vibrating. Normally you would listen for it also, but she's been having a bunch of good sessions, so we're not worrying about any kind of outflow stenosis, which means that there's a narrowing inside of the tube. So instead of it being this open, it could be this open and have a lot of extra pressure inside. We don't have to worry about that. Not right now. So, we're going to make an insertion site here and here. But first we're going to clean it.
Oh, and I'm wearing a mask because I have a cold and I can't spray any germs to the site, the arm.
Now normally when you're in a in-center, the dialysis tech will have personal protective equipment, which will be a gown that's resistant to liquids like blood, a face shield, which is also protective against blood, or some kind of goggles and a face mask and gloves. Since we're home, we get to kind of bend the rules a little bit. So all I have to do is wear gloves. If I get blood on my shirt, I'll wash it, no big deal. If I get blood on my face, I love my wife, I don't care. But if I were to have a cold also, I would have to wear a mask. Right now she's using alcohol because we don't like using the iodine. It also takes too long to dry. We want to get this over and done with. But the alcohol is effective in disinfecting the insertion site. 4 swabs each site. And you swab for 15 seconds each. So it's about a minute of cleaning for each site. Benefit of using alcohol is that it dries quick and you can do what's called a wet stick. These are the arterial fistula needles. Arterial red, venous blue. Right now we're going to use the red one. We're going to go above the previous site here where there was some work done.
If you can't stand blood, now's the time to turn your head.
Turn away. It's stabby time. You go in at a 45-degree angle. Careful not to go too fast or too hard, because if you come out the other side, it's bad. Once you see a flash of blood where you actually see a pulse, it's about there. Now we level the needle out and advance it inside the tube. My trainer does this a lot faster because she's been doing this for 10 years. I take my time because I'm paranoid and I don't want to hurt her graft. You don't want to advance it all the way up to the hub of the needle, because then that'll open up the insertion site more than it needs to be. As long as you see this nice beating of blood here, you're good. Now the first thing you want to do after you get the needle in is secure it, because sometimes people's blood pressure can make that sucker jump right back out, and then it'll look like a murder scene. Now you want to take, usually in a home hemo center, in a regular dialysis center, they'll just use gauze. We'll use band-aids to save our gauze. We cover the insertion site with a clean dressing to make sure nothing gets in there. Get some more tape to further secure it. Now the machine here is clean, so you can put your tape there for the meantime. Make a little chevron here to keep the needle from wiggling back and forth. And one more piece of tape for good luck to secure the entire thing. Now we proceed to cleaning the second site, which will be for the venous needle. And the rule of any kind of dialysis is you want to keep everything clean and or as sterile as possible. Once something hits the floor, it doesn't matter anymore. You go and get a new one. So, if things hit the floor in the course of setting up, leave it there until you're done, because you don't want to have to go through the hassle of going and get another, cleaning your hands with either soap and water or alcohol-based gel, and then re-gloving again. Just leave it on the floor. Nobody's going to die, as long as you're not stepping on anything that's going to stab you in the foot. And now here we go with the venous needle. You want to keep the needles at least 1.5 inches apart to prevent recirculation of the blood, which means that the blood will be going out of one needle and in the other instead of going to the machine. Now for all those watching, we're going to cite policy and procedure. You didn't see me do this. You're not supposed to flip a needle for just willy-nilly. But see, it makes it a little easier for the blood to come out of the needle and back into the vein if you do it. You only want to do that really for the venous needle. Some people do it for both because they claim that it helps the blood flow both ways. But you also run the risk of damaging the access, because you could be scraping along the inside of it, not realizing it. And since none of us have x-ray vision or are from Krypton, we don't know what's going on, so we want to avoid doing anything that might damage the access, which is the lifeline of a dialysis, hemodialysis patient. So again, securing the site. Wunderbar. Now, here's the fun part. With the venous tubing, you're going to open up the cap a little bit, let the blood flow out, and stop it before it comes out. I want to clamp it here. Make sure it's nice and secure. Now is when we administer medications if necessary. This first one we're going to administer is Epogen. Epogen is a synthetic hormone that the kidneys have trouble producing. This synthetic hormone tells the bone marrow in your body to produce red blood cells, which is very important because in a lot of dialysis patients are anemic, so they need all the red blood cells they can get. Red blood cells also carry oxygen, which is essential for living.
Also, you must never, ever, ever touch the top here.
Don't touch this, because any bacteria that is on your gloves that you cannot see will get in there and go right into our bloodstream. Goodbye, patient. So you want to keep it as clean and sterile as possible. Now, as we see here, sometimes there's a little blood spillage. We want to clean that up as soon as possible. So we always have extra alcohol handy to clean it up. Get rid of that. This next medication is called heparin. Heparin tells the blood not to clot. It's a blood thinner, for lack of a better term. And we introduce this to the hemodialysis patient so that as her blood goes through the tubing and through all the thousands and thousands of tubes inside the dialyzer, it doesn't clot and allows her to get back as much blood as possible at the end of her treatment. Now that that's done, we're going to hook up the venous side first. Again, being careful not to touch the tips.
Right.
Make sure it just connects to itself. Now these lines have already been primed with normal saline, which is a mixture of water and sodium. This helps to get all the air bubbles out of the system and also acts as a hydration agent later on. It helps to push the blood back into the patient's body. Right now, we're going to draw the blood out through the arterial and make a little mess, but that's okay. That's why we have the extra alcohol pads. Again, we take certain liberties right now because we're at home and it's our home environment. Normally in center, as soon as you have any kind of blood come in contact with your gloves, you change out, because little microscopic holes in your gloves could accept microscopic organisms in the blood, and we're still got blood all over us. Gauze and alcohol pads are your friends.
Especially alcohol pads.
Alright, now we open up the clamps. And again, liberties at home they were allowed to do. In center, you don't really do this too much. You'll use clamps and clamp the tubing to the patient's clothing. But we're at home, and my wife likes to have her arms open because she's at the gun show. So we tape these to her. We never ever secure lines to an inanimate object, because if something goes wrong, if that inanimate object falls through the floor, we don't want it ripping the needles out of the patient's arm. Now, over here, we're going to press the button and go to figure out how much extra fluid we're taking off the patient. So this is the ultrafiltration rate. Takes out liters per hour, milliliters per hour, taking off 2.4. This is the total dialysate that's in all these bags. When we come back to the home screen, this will say how fast it's going to take off that fluid. It's going to take off 1 liter per hour. Now it will increase the dialysate flow rate. And this is your baseline. This is what we're starting out with our blood flow rate. This will change as we go forward in the beginning of treatment, as will the dialysate flow rate. This is a preliminary time. It's 6 hours and 11 minutes. We're not going to be on the machine that long. As we increase the blood flow rate, everything else will speed up and the time on the machine will decrease. So Mika has her blood pressure cuff on, and we are beginning treatment. Now, as you'll see, the venous side is going to clear up because it's pushing the saline into her system, and it'll come back out mixed in with her blood and then come out as extra fluid.
And it tastes very nasty.
The arterial side is filling up with blood, going into the machine here, coming up through all the tiny fiber straws here. And there's your dummy alarm. That was the alarm that told me I didn't unclamp the line for the waste going into the toilet. Certain codes will come up here. If you see them often enough, you'll know exactly what they are before you even finish reading it. So now her preliminary blood flow rate is already at 106. Her venous pressure, rather. Her arterial pressure is not reading yet because there's not enough of it coming out. So we're going to suck some more blood out. We're going to increase the blood flow rate to 300. It's 300 milliliters per minute that's coming out of her body and going through the system, which increases her venous pressure. That's the pressure of the blood going back into her body. We increase the dialysate flow rate to compensate. Basically, it's a lot like friction inside the dialysis, inside the dialyzer. You can't get dirt up off a countertop without really scrubbing it. The same thing here. The countertop is the blood. Bad stuff in the blood is the dirt. The dialysate is the Brillo pad. As it's moving back and forth against the blood, that's how it gets all the bad stuff out. So now that we're seeing that her pressures are within acceptable tolerances, we'll increase it to a maximum flow rate of 400. Her arterial pressure is going up. That's how much blood is, how the pressure of the blood coming out. Her venous pressure is going up. That's how much is going in. And due to some stenosis and some stents that are already in place, her pressure in that spot is going to be a little high at times. Increase the dialysate flow rate to a max flow rate of 11 liters per hour. And as her treatment goes on, the venous pressure number will decrease as everything starts to settle into a nice rhythm. And then we record everything on a flow sheet here. Her start time was 6:36. The time that we introduced the Epogen and the heparin go in here. The actual start time. Her blood pressure, which is on that monitor there, 128/77, a pulse rate of 105, which is a little high, but that's because she's on camera and she's near me. So I set your heart to flutter. And that's it. We continue to monitor every half hour. Well, in the first 15 minutes of treatment, we'll take another set of readings. And if there's anything going on that we need to alert the nurse to, we'll write anything here, like if I had to give her extra saline because her blood pressure was going down, or if she started cramping or if she farted too hard.
Oh, stop.
But after that first 15 minutes, every half hour after that until treatment is over, the machine will stop and go through a series of pressure tests to make sure everything is okay, and will document all the numbers and readings off of there. At the end of treatment, you take a sitting and standing blood pressure, pulse rate, her temperature to make sure there was no incidences of infection or any kind of pyrogenic reaction, which is basically the body catching a fever because something hit her system that it wasn't supposed to. How much time she was on the machine, how much dialysate, her ultrafiltration, which is the amount of fluid that came off, her blood volume process, which is how many liters of her blood was actually cleaned, and the status of the dialyzer. If it was clear, which is always good, streaked is meh, clotted is bad, because that means that was less blood that went back in her body. And then the post weight, which should be 2.4 kilograms less than her original weight, which would be 121.4. They measure everything in kilograms because that's an easier way of monitoring any kind of fluid gain in her system. And that is our home hemodialysis training seminar. Now, I know there's probably some things that everybody will scream about. Again, there are certain liberties that we take at home that we can't do in center, and there are certain things that we probably didn't discuss because we didn't script it, we just went off our memory. So, any questions, comments, concerns, feel free to leave them in the comments, and we'll see you later. Bye.